Our next speaker for this session shall discuss to us how to manage giant prolactinomas. Dr. Maningat-Goco is also a diplomate and fellow of the Philippine College of Physicians and the Philippine Society of Endocrinology, Diabetes and Metabolism. She is currently the head of the Diabetes, Thyroid, and Endocrine Disease Center of St. Luke's Medical Center Global City, and she is also a clinical associate professor at the UP PGH Division of Endocrinology, Diabetes, and Metabolism, while being an active consultant as well at the Cardinal Santos Medical Center. She was an visiting investigator at the Rockefeller University in New York Laboratory of Biochemical Genetics and Metabolism from 2016 to 2020. Dear colleagues, let us all welcome Dr. Patricia Maningat-Goco. Ma'am, the virtual stage is yours.
I'd like to thank the organizers for this kind invitation. And today, the title of my lecture is Giant Prolactinoma, a Giant Size Challenge. My objectives are, at the end of this session, the listener will be able to define and differentiate giant prolactinomas from other pituitary tumors, discuss the signs and symptoms of giant prolactinomas, select the appropriate diagnostics and management, discuss management issues specific to our setting, and to address the need for multidisciplinary and multimodality management of giant prolactinomas. We will follow this outline, a brief review of the pituitary gland and prolactin regulation, discuss what makes it different from other prolactinomas, the approach to diagnosis and treatment, and management issues. So let me start with this case that was lent to us by Dr. Franz Magnayev, PGH Endocrine Fellow. So this is the case of a 54-year-old male who works as a driver whose chief complaint was blurring of vision, which started 4 months prior to admission, and this was accompanied by frontal headaches. The symptoms persisted, so a month prior to admission, he consulted, and a CT scan was done showing a sellar suprasellar mass. He saw a neurosurgeon and was advised surgery. He was then admitted to PGH, and he was referred while awaiting surgery already at the wards. His hormonal profile showed normal thyroid function tests and normal cortisol. Initially, the prolactin was more than 200 nanograms per milliliter, but upon dilution, it went up to 7,000 nanograms per milliliter. The CT scan done prior to admission showed a large sellar suprasellar mass, 4.5 by 3.5 centimeters. An MRI later showed a slightly smaller lesion, 3.9 by 3.2 centimeters. But this lesion had signs of being aggressive. No? It showed wall erosion. It reached the optic chiasm, and then to the right, it extended to the right cavernous sinus and enveloped segments of the right internal carotid. Posteriorly, it was bulging into the pons, and inferiorly, it eroded the sellar floor. On visual examination, the patient had bitemporal hemianopsia. So let's go to a brief background. So the pituitary gland regulates many of the functions of the other endocrine glands. No? So it's composed of an anterior and a posterior pituitary lobe, and the lactotroph cells, which produce prolactin, are found in the anterior lobe. Attaching it to the hypothalamus is your stalk or infundibulum, where we find the pituitary portal vessels. Now, its anatomical relations: laterally, the cavernous sinus, which contains the internal carotid arteries, cranial nerves 3, 4, and 6, as well as some branches of the trigeminal nerve. Superiorly, we find the optic chiasm, and inferiorly, the sphenoid sinus. Now, the regulation of prolactin secretion occurs at several levels. So at the hypothalamus area, the pituitary, and the systemic circulation. The secretion of prolactin is tonically inhibited by dopamine, and it is stimulated by thyrotropin-releasing hormone and VIP. So if you have patients with hypothyroidism, because of the feedback, there's an increase in TRH, so there's an increase in prolactin secretion. While antipsychotic drugs or antidepressants, as well as lesions which block the action of dopamine, will increase your prolactin secretion. Prolactinomas, of course, secrete prolactin, and estrogen will stimulate the secretion of more prolactin. Patients with renal failure will have an increase in prolactin because of a decrease in the renal clearance of prolactin. Okay, so if you have an extracellular tumor which impinges on the infundibulum, you'll have what's called the Stock effect. And because of that, there's lactotroph hyperplasia and an increase in prolactin, generally less than 200 nanograms per milliliter. If you have a prolactinoma which constantly secretes prolactin, the high prolactin levels are generally more than 200 nanograms per milliliter. So what differentiates a prolactinoma from a giant prolactinoma? So briefly, let's review. Prolactinomas are the most common secreting tumors of the pituitary, accounting for about 40% of pituitary tumors, and the prevalence is about 5 per 10,000. The size is what generally differentiates the different prolactinomas. So micro is less than 10 millimeters, macro is more than 10 millimeters, and giant is more than 40 millimeters. Giant prolactinomas account for only 2 to 3% of all prolactinomas and only 0.5% of all pituitary tumors. Male to female ratio is 9:1 and generally diagnosed between 20 to 50 years old with a median age of 42 in males. There is no standardized definition for a giant prolactinoma, but if you look at the literature, the generally accepted size is more than 4 centimeters or 40 millimeters, a prolactin level that is more than 1,000 micrograms per liter. They're generally more aggressive and invasive. And another criteria that has been proposed is that there should be no other hormonal hypersecretion, such as ACTH or growth hormone. Now, what do we know about giant prolactinomas? Again, it's more common in males than in females. And it's not only because of delayed diagnosis. There's actually a higher lactotroph proliferative activity in the tumors found in males. There's also increased tumor vascularization because of increased VEGF2 and FGF2. Despite being more aggressive and invasive, most giant prolactinomas are benign tumors. They are also highly responsive to medical treatment with dopamine agonists because the mitotic rate and proliferation index are only slightly increased compared to other prolactinomas. So in this review of 15 studies with a total of 140 patients published in 2014, they found that the male to female ratio was about 6:1 in the study. The average age was about 41 years old. Prolactin at diagnosis was about 6,400, and the tumor diameter was more than 5 centimeters. Going to the symptoms of giant prolactinomas, most of the symptoms are because of the mass effect of the tumor. So you have visual problems, headache, and hypogonadism, which are the most common symptoms in males. The duration of the symptoms before the diagnosis ranged from as short as 1 day to 240 months, with a median of about 8 months. In females, the most common symptoms are primary or secondary amenorrhea, headaches, visual problems, and galactorrhea in patients who are diagnosed at a younger age. So the symptoms actually depend on the direction of the extension of the tumor. Remember, these are invasive and aggressive tumors. So if they extend superiorly, you can have visual defects, hydrocephalus, cognitive dysfunction, and focal neurologic symptoms. Inferiorly, there's nasal obstruction, sinusitis, or CSF rhinorrhea. It extends laterally into the cavernous sinus where you find the cranial nerves. There could be cranial nerve paresis, temporal epilepsy. Anteriorly, you can have proptosis or optic nerve compression, and posteriorly, you can have gait deficits as well as hearing deficits and tinnitus. So just briefly to summarize the difference of the different prolactinomas, we have micro, macro, and giant prolactinomas. In terms of size, this has been emphasized previously. For prolactin levels, it's more than 250 generally for microadenomas, more than 500 for macroadenomas, and more than 1,000 micrograms per liter for giant prolactinomas. Whereas it's more common for females to have microprolactinomas, macro and giant prolactinomas are most commonly found in males, and the presenting symptoms in microadenomas or galactorrhea or menstrual symptoms, whereas for macroadenomas, it's the mass effect that predominates. So next, diagnostics. So the MRI is still the imaging modality of choice. And here we see a sagittal section of a normal pituitary. So here we see the optic chiasm, the stalk, and the pituitary gland. And here is a coronal section. So comparing it to the cartoon, we see the pituitary gland and the stalk and the optic chiasm. But in real life, most of the images that we get are probably not this good. So we will need the help of our radiologists to read our MRIs. But it's really not hard to miss a giant prolactinoma because they're really huge and they're invasive. So here we see a sample of prolactinoma. In terms of the prolactin assays from the publication in 2011 for the practice guidelines for hyperprolactinemia, it's recommended that you can do the assay at any time of the day without the need for fasting. Should consider stopping the medications that can affect the prolactin assays if you're able to. Should avoid excessive venipuncture stress, and a single determination is usually sufficient to establish the diagnosis. What if you have a large tumor and your prolactin is only slightly elevated? So you have to consider the hook effect. So this is a problem in these sandwich antibody assays. So here you have an anti-prolactin antibody, which is fixed. And then you add on your sample, and you want to determine the level of prolactin. Then you add on your labeling antibody. So if you have a successful sandwich assay, then you're able to detect the right amount of prolactin. But if you have excessive prolactin, then they can bind to both labeling antibodies, and you have a falsely low amount of prolactin detected. So what you need to do is to repeat this, submit another sample, and request for a dilution at 1:100. So if you get prolactin level, which is much higher, like with our sample case, from 200, it went up to 7,000, then you're sure that you're dealing with a prolactin secreting tumor. But if you get a repeat that is still similar, then you should also consider a non-prolactin secreting tumor causing the stalk effect. For treatment, we still have a lack of evidence-based data because of the rarity of this tumor. So most of the data that we have are from reviews and case series. For therapeutic goals, they're basically the same as our goals for the treatment of macroprolactinomas. And these are the goals: normalization of hormone levels, reduction of the tumor size with a rapid relief of the mass effects. Significant response is pegged at 30% reduction in tumor diameter or between 50 to 65% reduction in tumor volume, depending on the publication. The third goal is the restoration of eugonadism. However, these goals are not always achievable in giant tumors. For treatment, we may ask these questions. Now, what is the first line of treatment? And what are the complications of initial therapy? And should medical treatment be more aggressive for these giant prolactinomas versus the other macroprolactinomas? The first line of treatment for medical therapy are your dopamine agonists. So they play a primary role in the treatment of giant prolactinomas, even in the presence of severe or unusual neurological symptoms. So the two most common that are used are bromocriptine and cabergoline. In terms of efficacy, cabergoline has been shown to be superior, probably because of better binding to the D2 receptors. It also has less side effects. However, the cost is much more expensive. But when it comes to availability, only bromocriptine is available, and it's about 192 pesos per tablet here. Cabergoline is not readily available in the Philippines. I have a patient who's able to source it, and she's able to get it at about 700 per tablet. Okay. So from the different studies, we know that dopamine agonist treatment works, and those who achieve complete biochemical response actually needed a lower dose of cabergoline, probably implying that these tumors are more sensitive. A higher prolactin at diagnosis also had better response to dopamine agonists, probably also indicating that these tumors are well differentiated and are more bioactive. Some observations are that the prolactin levels usually reach a low about 12 months into treatment and can reach normal levels. Prolactin can decline more than 99% and the tumor volume can decrease by more than 96%. Prolactin normalization can be achieved in about 55% of patients with giant prolactinomas. Headaches and visual field improve in most of these patients. Now, in this review of 13 case series and a total of 97 patients who received medical treatment with bromocriptine, cabergoline, or pergolide, 96% of the patients had visual defect improvement, 74% had a decrease in tumor size, and 60% had a normalization of prolactin levels. About 14% eventually needed surgical treatment, and the reasons were intolerance to the medication, insufficient response, tumor growth, and CSF rhinorrhea. Similarly, in another case series in Mexico with 42 patients who were treated with cabergoline, the median dose of 2 milligrams per week, 68% had visual field defect improvement, 87% had a decrease in tumor size of more than 50%, 68% had normalization of prolactin levels, and 14% also needed surgical treatment for similar reasons. Visual field improvement with medical treatment occurs in as short as 2 to 15 days. It's published in this study in 2002. And complete normalization can be achieved in 48% of patients. For the recovery of hypogonadism in the series done in Mexico, 32 out of 42 achieved eugonadism, whereas in this study where they looked at patients with giant prolactinomas that were more than 6 centimeters, a smaller percentage, 37%, achieved eugonadism. So in this publication by Shimon, just in 2019, where he reviewed 6 case series, the response to medical treatment based on prolactinoma size is given. So here on the left-hand side are the sizes, micro, macro, and giant prolactinoma was divided into more than 40 millimeters and more than 60 millimeters. So for microadenoma, of course, visual damage, there was none. Surgery was rarely needed. Prolactin normalized in up to 95% of patients, and testosterone normalized in 90% of patients. Now, for macro versus giant prolactinoma, visual damage was present in up to 50% for macro and in 70 to 80% of giant prolactinomas. Surgery was needed in 5 to 10% of macroadenomas, whereas it was 15 to 50% in giant prolactinomas. Prolactin normalized in 90% of macroadenomas and about 60 to 68% in giant prolactinomas. Testosterone normalized in up to 70% for macroadenoma and in 37 to 67% of those with giant prolactinomas. So in terms of prolactin normalization and testosterone normalization, it was a bit lower here for the giant prolactinomas. Now, what are the indications for surgery? So for surgery, the indications have been biochemical or structural resistance to dopamine agonists, and this is defined as the failure to achieve a normal prolactin on maximally tolerated doses of dopamine agonists and a failure to achieve at least a 50% reduction in tumor size. Medication intolerance, apoplexy, and intracranial hypertension. Visual field defects was an indication for surgery in the past. So as initial therapy, surgery was preferred in the past because it was thought that it would provide more rapid resolution of neurological symptoms. However, it's rarely curative, and most patients will not achieve hormonal remission postoperatively. There is significant residue of the tumor, and most will require continuous medical treatment after the surgery. It's also accompanied by significant morbidity. So in this study of 30 patients published in 2005, 18 of the patients received surgery as initial treatment. And they found that in all these cases, there was only subtotal removal of the tumor. There was partial decompression in 11. The prolactin remained at more than 200 micrograms per liter in all the cases, and there was 1 death. Other complications included diabetes insipidus, deterioration of vision, mental symptoms, and cranial nerve palsies. Now, they compared it to a cohort of 12 patients who were treated with bromocriptine, which was the drug that was available in their center. No? And what they found was that tumor volume reduction was better in the medical group. The prolactin reduction was similar in both groups. No? And visual improvement was similar as well in both groups. So the conclusion of this study was that medication is the superior initial choice to reduce tumor volume and to control prolactin levels effectively. Now, in probably one of the larger series here, this is a review done in the Mayo Clinic, no, a retrospective review over 20 years of 71 patients with giant prolactinomas. And this was defined as more than 4 centimeters in at least one dimension. So in this review, 51 patients received dopamine agonists as initial treatment and 20 with surgery as initial treatment. Again, emphasizing that this was done basically before 2008 because their treatment recommendations changed after. So among the ones who received dopamine agonists as initial therapy, 38 just needed medical treatment, whereas about 10 needed additional surgery and a few others needed radiation and somatostatin analogs. Whereas the ones who received surgery first, only one was managed purely by surgery. 18 out of the 20 needed dopamine agonist. One needed repeat surgery, and eventually dopamine agonist was needed as well. So looking at their entire cohort, looking at their approaches and outcomes, so again, 51 received first-line dopamine agonist and 20 received surgery as first-line. But overall, 98.6% needed dopamine agonists. No? A few others needed radiation and additional treatment. At follow-up, 45% had adrenal insufficiency, 67% had hypogonadism, 50% hypothyroidism, and combined deficiencies here, 52%. But a more interesting analysis is looking at dopamine agonist monotherapy versus multimodal. So this is medical with surgical and radiologic. Initial prolactin levels were higher in the dopamine agonist monotherapy. Tumor size was not different. Okay, and you see here, all of these parameters are not significant. So for cabergoline treatment, the starting dose at 0.5 to 1 milligram per week. And then the maximum dose was about 2 milligrams per week with a wider range here. Maintenance dose was about 1 milligram per week. Okay, so that was not significantly different. For bromocriptine as well, the starting dose was 35 milligrams per week. Maximum dose about 105 to 140. And the maintenance dose 52 milligrams per week. For complete biochemical response, it was similar in both groups, about 59% in the dopamine agonist monotherapy and 69% for multimodal treatment. And complete structural response, 25% versus 27.6%, not significantly different. Another analysis they did was surgical versus non-surgical. For the non-surgical group, the baseline prolactin was significantly higher. Tumor size and apoplexy and need for radiation was similar for both groups. But what is interesting is that for the surgical group at follow-up, there was a significantly higher levels of adrenal insufficiency, hypothyroidism, growth hormone deficiency, diabetes insipidus, and combined deficiencies. Complete biochemical response was similar in both groups. Complete structural response was also similar for both groups. So overall, there was a 99.6% decline in prolactin levels in these patients with 55% normalization. And the tumor volume decreased by about 96.8%, and 26% of these patients had no visible tumor on follow-up. The conclusion of this study was that most patients with giant prolactinomas have excellent response to dopamine agonists. Now, we do have some local data, and I hope that we're able to compile more. And this is courtesy of Dr. Belle Pilet from PGH. Now, so currently, she's analyzing data. She has data on 23 patients with macroprolactinomas, but only 2 fulfilled the criteria of more than 4 centimeters and more than 1,000 micrograms per liter. 6 of these patients had tumor sizes more than 4 centimeters. but they did not have a repeat prolactin with dilution. Okay, so I think the giant prolactinoma data is still a bit too small. No? So among the ones with giant prolactinomas, one showed a decrease in tumor size and one still had residual tumor post-op. So I encourage everyone not to report if they have cases of giant prolactinoma so we can accumulate more data. So to summarize, initial treatment, medical versus surgical, both modes of treatment are able to afford rapid relief of neurological symptoms, normalize hormone levels, and restore eugonadism. But in terms of complications, your surgical treatment initially will have more complications, DI, visual deterioration, cranial nerve palsies, as well as hypopituitarism. So are there any predictors of response to treatment? Unfortunately, there are none. They found that tumor response is not correlated with age, gender, cavernous sinus invasion, baseline prolactin levels, tumor size, or first-line dopamine agonist therapy. Should higher doses of dopamine agonists be started for these giant prolactinomas? Now, these prolactinomas are sensitive to dopamine agonists, and rapid tumor size reduction may favor CSF leaks and apoplexy. So the treatment protocol is similar to other macroprolactinomas, starting at 0.5 to 1 milligram per week, and then individually adjusting according to the prolactin response. This very recent publication said that if the prolactin levels normalize and you have a significant reduction in tumor volume, cabergoline doses are either maintained or decreased to the lowest possible dose. So no, it's not advised to start a higher dose or increase the doses more rapidly. Can dopamine agonists eventually be stopped, like with microprolactinomas or some macroprolactinomas? Now, after 2 years, they said you can reassess whether you can stop. Okay, so in this paper where they looked at 25 patients, 15 treated with bromocriptine alone, and 9 had initial surgery and then bromocriptine. This was a 10-year follow-up. At the last follow-up visit, 19 patients had normal prolactin levels. 14 of them were receiving low-dose bromocriptine treatment at 2.9 milligrams per day. Younger patients had a significantly higher rate of persistent hyperprolactinemia after long-term treatment. So again, no, doesn't look like dopamine agonists can be stopped. They need to be maintained almost invariably lifelong in patients with giant prolactinomas. They're required to maintain prolactin suppression and to prevent tumor regrowth. Withdrawal of the treatment poses a risk of rapid tumor re-expansion, but a dose decrease is possible if you have normal prolactinemia and this is preserved and if the tumor mass is controlled. What is the role of surgery in resistant giant prolactinomas? Again, the role is difficult to establish and the indication depends on the portion of the residual tumor, if it's potentially resectable, and of course, it's based on the experience of the neurosurgeon. Some would argue that surgery might lower the requirement for dopamine agonists after, but in this study of 31 males, they showed that partial tumor resection did not lower the dose of dopamine agonists needed for giant prolactinomas. So because of the excellent potential response to dopamine agonist therapy and the high operative complication rates, surgery should be reserved for those who demonstrate inadequate responses to medical therapy, but it is unlikely to provide actual biochemical or structural cure. What about other treatments? So radiotherapy does not normalize prolactin levels. For now, it's used as an adjuvant to multimodality therapy, and you have the risk of other pituitary deficiencies. Temozolomide has been used for other pituitary tumors, malignant pituitary tumors. It's an oral alkylating agent. For now, its use in giant prolactinomas is as a salvage therapeutic option for the clinically aggressive prolactinomas that remain uncontrolled despite multiple conventional treatment modalities. Some of the management issues. First is testosterone treatment for persistent hypogonadism. So as we saw earlier, not everyone is able to achieve eugonadism. Testosterone can be beneficial for sexual dysfunction, anemia, and osteoporosis. However, we have to be aware of the potential tumor enlargement when testosterone is aromatized to estradiol. Complications of long-term dopamine agonist use. This came up in patients who are treated with high-dose dopamine agonists for Parkinson's disease. However, cabergoline has been shown to be generally safe at doses for prolactinomas. There's no evidence of cardiac valve problems. Okay. But some patients have been shown to have impulse control disorder manifesting as hypersexuality, financial loss due to gambling problems, and reduced work performance. And the recommendation here is to decrease the dose of the dopamine agonist. For fibrotic valvular disease, if it is detected, then we need to stop cabergoline. Ensuring cabergoline therapy, the first 2D echoes should be performed within 6 months from initiating treatment, and then the frequency should be guided by the development of signs and symptoms of cardiac disease, but at least every 12 months. Another issue is medication availability and cost. So we saw that cabergoline is the drug of choice for giant prolactinomas, but it's not available here. The cost of all dopamine agonists is prohibitive for most, and sustainability is also a question. So we should work towards equal access for these medications since prolactinomas are quite common and treatable. And lastly, we need to emphasize the need for a multidisciplinary action between all the services involved. No? Everyone needs to be aware that dopamine agonists are the treatment of choice for giant prolactinomas. There should be a joint discussion with the patient prior to admission because it will be very difficult to dissuade a patient who's made up their mind already about surgery. We need a bigger database for better analysis of our Filipino patients, and we need to identify pituitary surgeons to improve the outcomes for patients who will need surgery. So in conclusion, giant prolactinomas are rare pituitary tumors. There's a lack of evidence-based data to date. They are responsive to medical therapy with dopamine agonists, and multimodality treatment is necessary for a minority of cases. Recommendations are an increased awareness of benefits of dopamine agonists for giant prolactinomas, better communication with the medical team, and improved access to the medications that are needed. Thank you for your attention.
The Philippine Society of Endocrinology, Diabetes, and Metabolism, through its organizing committee, appreciate the time and effort and the endeavor of our speaker, Dr. Patricia Deanna Maningat-Goco, for sharing her time and expertise on the topic management of giant prolactinomas. So we award this certificate to you, ma'am, for being our speaker for this convention. Again, thank you very much.